LED from its proximal part, and you can clearly see there is contralateral filling from the RCA. First of all, we tried with a pilot 50 wire with a micro catheter, but the pilot, you can clearly see that the pilot 50 wire is in the subintimal and its mid part, entering the, so parallel wire with the filtered ST, escalation of the wire was done at the filtered ST wire with a micro catheter, and you can see this, then the wire was in the lumen by giving a contralateral injection from the right side, and two stents were deployed, and these are the final view of the case. So in CTO, the guide wires are commonly used to cross. You can see low penetration wires. These are filtered ST in the right hand side, filtered XTA, they are Gaia 1, and in the intermediate penetration you can see the pilot 150, pilot 200, and Gaia 2. In the high penetration you can see the Conquest Pro, the Gaia 3, Gaia 3, and the so these are the these are the categories of the wire. In case of AMI setting, you can use a BMW round through CM Blue is a common wire available in our country. And if a tortuous vessel, you can use a whisper wire, pilot 50 or stone black. And in extra support cases, you can use a BHW wire, Garrison wire, where you can give good support to the device. And in the tough crossing to the CTO, where Miracle wire, Conquest Pro 912, Gaia series, and Choice PT may be used. So I acknowledge Professor Fazila Malik Madam and Dr. Professor Habibur Rahman in preparing me this lecture. In conclusion, appropriate guide wire selection can make it easier to overcome the difficult scenarios. Superficial choice of guide wires may not unnecessarily prolong the procedure, but also compromise its success. Operator therefore needs to aware of some basic properties and technical backgrounds of the guide wires and be familiar with them. Operators should have extensive experience and knowledge with fewer types of wire instead of having superficial knowledge with fewer wires, with superficial information about many of them. Distal tip of the guide wire should be carefully manipulated as it may cause life-threatening complications. Thank you all for patient hearing. This is our cabinet thing. Thank you.
Presentation. Due to time constraint, we are not inviting any questions. We are moving to our next speaker, Chaudhry Hafiz Ahsan. It will be very much appreciated, Chaudhry Hafiz Ahsan, if you customize your lecture due to time constraint, because next session will be live session.
So I'm here to fill in basically. So we are going live to National Heart Foundation at 10:15. So we're going to stop before that. So one of the most boring topics in any interventional conference is radiation. So let me show you a case. Maybe that will interest you. To pay attention to the radiation dose and what we need to do for radiation safety in the cath lab. So this is our patient who presented with multivessel coronary disease, referred from, actually we are getting these patients now with CTA first, high calcium score, go for a CAP, and this was done in a ambulatory care center, and this was the right coronary artery, and then this is the LAT. So the diagnostic was done and then was sent to us. So we did the team approach. Patients want PCI, we did the LAD, rotational atherectomy, and this was the final picture. So you look at the radiation in the first session, we did a stage. So this was AR karma 1.27. Okay, so now we bring back the patient for the right. And then this was plaque modification. We did the rota 1.5 bar, and then balloon, long balloon, and we started. Stent cannot be delivered, and then suddenly I realized this is the air karma popping up. See the orange? So what do you do now? I said. So I give analogy of cricket in cardiology because you know the limited time over, and then you have to finish. Bangladesh did excellent with South Africa. So and then the strategy. It's all about strategy, and we don't now have luxury of long innings, right? Test match. We have the radiation problem, contrast problem, and then in STEMI, we have the time issue also, and delivery of the care. So what we do in terms of radiation, and now we have a situation where we cannot deliver the stent. So the idea we tried long balloon, non-compliant balloon, and this was the situation.
Definitely, if I want to develop SLPs, but I would like to take, if I can't deliver the steps, I will take double body wear, then anchor with, and then last pressing, the hypertrophy of scientific. The two things I will take to deliver the step here.
So we did body wear. We are doing the mailman. Then we tried Godzilla, not working. And I think when I used the Godzilla and Godzilla not working, at that point, and I was really upset with the fellow. He said, "Did you look at the radiation dose?" And I said, "Oh, that's not good." So now we have to make a prompt decision. You know, like, when the captain sends the regular batsman, he sends somebody who is a high hitter, and then finish the innings. So what do you do now?
It's a difficult scenario. All these three things does not work, then definitely think otherwise.
So Ramesh, this is what I did. I said, what the heck? Let's get the 2-0 bar.
Yeah.
I started 2-0 bar, and I bought the whole thing, and then 48 millimeter stent, and get this case done. So what I'm trying to tell you that the radiation is also an issue. Contrast is also an issue. And in the case of an STEMI, it's all issue that there is a delivery of care and how we can get the best result. And not only the go-to balloon, also we need to make sure that the good perfusion is established. If we do go-to balloon, 45 minutes, but there is no flow. What's the point? So it is important all that. So in radiation world, we need to understand the dose, the total amount of ionizing radiation that is going in the air, and how much radiation is absorbed by the patient, and then what is the effective dose to cause these changes, and then the side effects from that. Like the COVID time, we learned this. This is from the cath lab. The time, distance, and the shielding. COVID analogy, exposure time, and then distance, and then protect yourself. We have learned this long time ago. And then those limits, we understand this. If you don't remember, at least I tell the fellows, remember from the night before the board exam. It will be in the exam. So the ionizing radiation, importantly, two types of ionizing radiation and side effects that we don't realize. That one is the stochastic side effects and the deterministic, the linear dose relation. But there is sometimes DNA changes that even any radiation dose can be a problem. And this typical question in the interventional board. They give you a graph and then ask you that what do you mean by the deterministic effects and then stochastic effects. And these are the important things, particularly those who are doing CTOs long time. Make sure that we have a discussion before, check out, see this in the after. So, confusing part, and this is a confusing part. There are many units used in the radiation. So, decaying the ionizing radiation that goes, it's like throwing balls that you call it in the becquerel, and then absorb those you call in gray, and the effective dose you call in sievert. And you need to understand what these sources are for the radiation. From the patient is the biggest source for us. Another big interest, important question for the board exam, that for the operator and for the assistants inside the room, the biggest source of radiation is the patient, not the radiation itself, because it is scattered. And then patient, with the imaging, with the body weight of the patient, there is automatic trigger that there is dose can go escalate. And for us, we protect us from this time shielding, but the few practical points, time. How much time we do the fluoro? Frame rate. Frame rate means that if you're doing it in 15 frames per second versus 7.5, 7.5 will give you obviously less radiation. But you get used to the images as we do fluoro. Fluoro save, that will help you to save radiation. All these are very important tips in the cath lab, and then make sure that we understand all that and use less angulations, less fluoro time, and make this habit not to check every time, every few seconds. And sometimes IVAS use also can help you to reduce radiation. So I will stop here. We go live at 10:15.
Thank you. Thank you to the Hassan. Thank you for your nice lecture. Now I get comments from Professor Nityaman, sir. Then to conclude.
Thank you. Conclusion will be done by Professor M.J. Aswad. Sorry, And I like to say a few words regarding this radiation hazard. As we are ignorant about radiation hazard, this is not acceptable. Particularly in my country, we are even many of our interventionalists, including myself, we are not using radiation bells. Also, I hope that everyone should use the radiation bells for own protection. Own protection is very much important in this intervention. We should do a complex intervention. Patient is all right. At the end of the day, performer is suffering from leukemia or lens opacity, this and that. That is not acceptable. So we must have to honor the radiation risk. Thank you.
Thank you, sir. Now, Professor J.M. Kharge, sir, to conclude the session.
There are a lot of discussions on this front aspect, but I'd like to bring some points to you also very important. One is the lecture was given by Carla that has really affected me. Certain issues, for example, the complex angioplasty. Complex angioplasty, as far as I am concerned, I find it very difficult to find out real pain. But the complexity is from the patient. The complexity